Welcome to the Kaleidoscope of Possibilities, Alternative Perspectives on Mental Health. My name is Dr. Adriana Popescu. I'm a licensed clinical psychologist and leader in the field of mental health, energy psychology, addiction, trauma, and empowerment. In this podcast, we will be exploring mental health from a variety of perspectives, from the spiritual to the shamanic and beyond. What if mental illness isn't everything we think it is? What if everything we see as a pathology is actually a possibility? What else is possible with mental health?
Hi, everyone. Dr. Adriana Popescu here with you today with another episode of Kaleidoscope of Possibilities, Alternative Perspectives on Mental Health. I'm really excited to have as my guest with me today, Deanna Chrones. She is a licensed clinical professional counselor in Illinois and a PhD student studying counselor education at Northern Illinois University. She received her Master of Arts in Clinical Mental Health Counseling from Northwestern University, where she graduated with highest honors. Deanna developed a novel psychotherapeutic intervention that we're going to learn about today called Tholáge Neuropsychotherapy, which has been studied at major universities and found to have large effect sizes in the treatment of PTSD, frequency and severity, depression, anxiety, and emotion regulation. Welcome, Deanna.
Thank you. I'm so happy to be here.
Yes, we're so happy to have you and to learn about this wonderful technique that you have developed. But first, as always on the show, we like to start with getting to know our guest. So tell us a little bit about yourself and how you came to be doing this work that you're doing.
Well, I can tell you I actually started in a different career. But when I was growing up, a family member completed suicide. And, I just couldn't help but notice the toll it took on different people in the family, myself included, in different ways. And it always intrigued me. And I just started to pay attention to what I was noticing in people, the people around me who had known this person who had caused quite a few issues in our world as we were moving through life. The people who could feel healthy, regulated anger toward that person were the ones that didn't seem to get symptomatic. And the people who couldn't access that did become symptomatic. And I always noticed that. And so when I got to a point in my life when I could make a change, I decided to, first I became a certified hypnotist, which is very fascinating. And I started to use some techniques that I had noticed that worked for me to access emotions that just felt way too dangerous to feel. And in fact, were dangerous in childhood, but just become less so when we get older. And then it becomes maladaptive to suppress them. And so it's okay and perfectly ethical to do that in hypnosis. But I decided along the way to become a counselor. And I did. And of course, everything I'm doing, I have researched through the literature, and then also now through some clinical trials and even a neuroimaging observation. And so I started using them with clients and just getting astonishing results. And so formalized the whole thing, and here we are today trying to get the word out about it and how it works.
So that's really fascinating, especially at this, like fairly early on in your career, that you've already developed this whole modality that now you're even getting some clinical trials on. So what exactly is Tholáge, and what do you use it for?
Okay, so Tholáge is quite novel in that it's largely somatic. We use body-based techniques to help people access specific neurochemicals. And there are reasons why we do that. Essentially, we're trying to do something that is a treatment for trauma, because trauma is at the root of so many other disorders. And so emotion suppression as well is a problem. It causes symptoms across many different disorders. So these techniques help affect those things. In other words, we can create changes to a traumatic memory by utilizing a couple basic steps. First, what we want to do is engage in something that's pretty common already in therapy, which is parasympathetic activation, or those calming techniques that people use. Mindfulness, anything that's calming to an individual, will release the chemicals associated with that rest and digest state. And we do it a little bit differently in Tholáge. We use somatic and some mentalization techniques to create ASMR, which is that tingling sensation we get if someone plays with their hair. Some people will watch videos to get that feeling. This is just purely empowering the client to use these techniques, little movements of the body or thoughts, cognitions, to affect ASMR. So they're quite novel. So we get that piece of it. And the reason we do that is because that helps to what's called destabilize a traumatic memory. So it kind of lets it be taken apart. And that's important because it's really easy to destabilize everyday memories. It's really hard to destabilize a traumatic memory. It gets locked in there really, really well. And that's why so many people end up with PTSD, or even after treatment, it just doesn't quite ever change because the trauma itself, all that release of norepinephrine during the trauma locks it in. So we do this destabilization, but then we do the thing I just talked about, right? We try to purposefully release norepinephrine in the next part of the treatment. So in one treatment session, which helps to close the memory back up, lock it back in. But in between those two steps, we're changing it. So we're trying to create with the ASMR feelings of safety and social connection, well-being, even joy, and that gets attached to the memory. Then we move into the other phase, which is the more activating phase that releases norepinephrine, which is also really novel, and I'm happy to talk more about it. And that releases a chemical that helps us access our emotional memory center. So things that were so dangerous to feel, like I talked about before, it wasn't safe for me in my life to feel anger. This, in my case, it was my father who completed suicide and who was problematic. And it just was never safe for me to feel angry with him. That would have been dangerous, and was dangerous, in fact. And so I learned to push that down. Well, we use a particular eye movement in Tholáge that is held in place. It's an upward eye movement, which I can show you later, that's held in place for a certain amount of time. And that has been demonstrated in the literature to activate the basolateral amygdala, which is the emotional memory center. So that lets, say, me, for instance, get in touch with healthy, regulated anger toward my father. And that might sound strange. You know, he's not here anymore. Why would you have any trouble feeling angry, or why would you want to? Well, we are very careful in Tholáge to differentiate between healthy anger and rage, or healthy anger and irritability. These are different, all different emotions. We want that genuine feeling. It's not pleasant, but when we suppress it in adulthood and we're actually safe now, it's not healthy for us. It leads to symptoms of PTSD, depression, anxiety. It can lead to eating disorders, OCD. And so in one fell swoop, if you will, we use this one eye movement, eye position, to both turn on the sympathetic nervous system and to access emotions that were pushed away and feelings of empowerment. Because if you think about it, activating sympathetic at the same, which is the activated even fight or flight in a controlled setting with your therapist, and activating the emotional memory center helps you get in touch with important emotions that you have always tended to push away, and gives you a strong, empowered feeling while you're doing it. So that's more change. So we're creating all this change to what our bodies feel like, what emotions we're experiencing, even thoughts that we have. We do re-narration in this process. And then the sympathetic, that eye movement that I talked about, helps to reconsolidate. And that's what the literature has shown for decades, that norepinephrine, which is released by this eye position, closes memories back up. And in fact, that is what caused the trauma in the first place. But now we're changing the entirety of that traumatic memory and then closing it back up and kind of locking it in this new form. So that's the big picture. Wow is right.
Wow. I mean, it's so sophisticated and so really scientifically based. I kind of want to break down, because I think for some people, they might be a little like, whoa, that went over my head.
It's a lot. Perhaps
yeah. So let's break it down a little bit to kind of some key aspects. Like one, I mean, and I often talk about on the show, just as part of kind of educating people, because I feel like, the average person certainly doesn't get this kind of information about growing up or in school or anything. First of all, trauma is something that we experience physiologically and not just psychologically, right? It's not just, I was scared, or I was extreme panic, extreme anger, whatever. But like, there's all those emotions, but there's also physiological things going on. We've done a lot of conversations on this show about like the fight, flight, freeze response. And we talk about the amygdala, right? And nervous system activation and polyvagal theory and all of that. So can you just, in like really simple terms, explain for us what it is about a traumatic experience that affects us physiologically, that makes it so like we get stuck with it, or we get stuck in it? We don't seem to be able to like move on from it, because a lot of people say, well, that's in the past, get over it, move on. And we know it doesn't work like that. So can you educate us about that?
Absolutely. And thank you for taking me back to the beginning, because that is the best place to start, right? Well, technically, what happens when somebody becomes traumatized by something, and of course, it doesn't happen for everybody. We don't know exactly. They're really researching nitty gritty on this into the chemicals in the brain. But can we say why two people can go through the same trauma, one person develops PTSD and one does not? I don't think anybody can say that yet. But what we do know is anytime something traumatic happens, for some people, for most of us, right, there is a big release of something called norepinephrine. That's essentially the adrenaline for the body that makes us
stress hormone, right?
Right. It's the stress. It is a stress hormone, and it's related to cortisol. It's not the same thing, but they're both in the same family, if you will. And that is a survival technique. That's actually a good thing. If you hear a loud noise and you're not really paying much attention, you're doing something else. Once you hear that loud noise, if it's scary enough, if you know what it is, you won't really react this way. But if it's indeterminate what that is, your nervous system will release norepinephrine. What does that do? It activates fight or flight. It tells you, pay attention, be alert. There's something to focus on, and that will help you focus on that, interpret what it is, learn what it is, and if it's dangerous, it will tell you to flee, right? If you realize that it's just a car backfiring or something, your nervous system calms back down. And actually that's another conversation, but when we really calm down and release norepinephrine and then it shuts off because everything's okay, we can actually go all the way into parasympathetic and get really calm again, which is an interesting homeostasis aspect of the body. But in general, yes, norepinephrine is there to help us. The problem is something about that chemical can really make it difficult to, as I said, destabilize or change a memory. When we learn something normal every day or non-traumatic, it's very malleable. Memories are very changeable. And that might seem weird, but if you think of memory, you should think of it akin to learning, because any fact that you learn in school is essentially a memory, right? And you need to be able to update that when you get new information. So memory is designed to be changeable. The problem with something like PTSD is it doesn't change, it gets fixed. And so all the physical associations, like you talked about, maybe a racing heart, sweating, shaking, whatever it might be, gets tied to that memory, along with the emotion of maybe fear constantly surveilling our surroundings to see if we're in danger all the time. Even when a person is clearly safe, they'll still be doing that. And the thoughts that they have all gets tied together and gets locked in. So I hope, did that help explain?
It does, yeah. And then and all of it, it's almost like I think of it when I explain it to clients. It's like part of you gets stuck in that experience. And then like PTSD, or what we call unresolved trauma, is like replaying aspects or re-experiencing those aspects. Maybe it is the physical somatic symptoms, maybe it's intense emotions or fear or whatever, the hypervigilance you mentioned, but there these after effects that linger on. Is this, in a sense, you are still re-experiencing that traumatic experience in some form or another. And then we have these trauma triggers, right? Like it could be something associated with that memory, a smell, a sound, a song that was playing, a specific location. Just encountering that stimulus can activate this whole, like, get the whole thing going again, like trigger all the chemicals, get the amygdalas activated, the heart is racing, all the things, as if it were happening right now, even though clearly it's not. Like I always give the example of the war veterans who, you know, on the 4th of July hear the fireworks and think they're back in combat, right?
Right. Absolutely. And the other thing to think about with this is the lengths to which people will, with PTSD, part of the definition of it, right, is the avoidance of anything that might even possibly remind them, which shuts down so much of life for them.
Right, because you decided it. I feel like there's this piece where you felt so powerless and helpless, or it was so overwhelming, you decided that you couldn't handle this. Right. And so then, especially if we're young and children, we really don't know how to handle these things.
Absolutely.
We end up suppressing, repressing, like you said, right? All that emotional stuff. And we know that now we know that a lot of that lives in the body. You know, I used to be a massage therapist, and I would touch a certain part of someone's body and they might burst into tears, like not even aware that, all of this painful stuff that I went through is still with me.
Right. It's amazing what we carry. And people can, you know, I've treated people in their 7th decade of life, 8th decade of life that have carried traumas from childhood. And of course, the more complex the trauma, the more difficult the problem, because now you're talking about a number of different things that probably have happened. And that is a big aspect of something else we treat in Tholáge, if I may say, is that it's even more difficult. That when I talked about anger, there's a big component to Tholáge that is really designed to treat complex trauma. In other words, things that happened in childhood or adolescence multiple times that relate to either a caregiver or some other important person in life. But when we're little, as I was alluding to before, maybe that person, you know, we're safer living in that house than out on the street. And there's an adaptive response. I don't think anybody knows exactly how children understand that. But the truth is that even in the most dangerous households, most of the time the child is safer there than trying to live on the street where they wouldn't survive a day. So they just learn to suppress so much. Maybe they'll feel it for a bit, but something will remind them, like you're saying. And then they're like, no, I have to shut that down. It's too scary.
Yeah.
When in fact, emotion suppression, as I said, leads to symptoms of so many mental disorders and causes so many problems.
Right. I mean, you know, more and more, it seems to me, I think, especially since the dawn of polyvagal theory, more and more, I think we're understanding kind of more from a scientific perspective that pretty much all mental health, it's so ironic to call them mental because it's so much more than in your head. It's that all these different mental disorders have some level of nervous system dysregulation, right? Yes. Or inflammation. That's a whole nother topic.
Well, it's true. And every time we do a clinical trial, we're on another one. I'm leading through my work as a PhD student. We always measure for emotion regulation. So we're not just measuring symptoms of PTSD severity, PTSD frequency, depression, anxiety. We look at various measures of emotion regulation because you're exactly correct. It lives in the nervous system.
Right. Right. And so much of this is why I think traditional talk therapy has fallen short, because, CBT is great when you're calm and can think rationally. But if you're highly anxious or in a panic attack, I'm sorry, you're not going to be able to reason with what evidence do you have that you're not having a heart attack right now? Like that's not going to work. You have to get the nervous system calm and get this part of the brain back online before someone can use a tool like that to kind of think their way, rationalize their way through something, right?
It's absolutely true. And something else along the same lines of what you're talking about is that the literature tells us, and look, there are lots of treatments out there that are, effective in different ways. There's research to show that for sure. But in the last few years, where they're really diving down, and we won't go there, but into even deeper levels of chemistry, I guess, than I've been talking about. What they're finding is that, let's say with something like prolonged exposure, you have the person come in and just talk about the same traumatic event many, many times over and over and over again. In this case, in that case, what they're trying to do is remove the fear and the physiological responses that go with fear, because the person has said it so many times it like loses its sting. But that takes a very long time. And what the research is really showing is it actually, I sort of think of it as creating a vacuum. You can take an emotion away, but then what are you putting in its place? If you're not replacing it with something really purposefully, it can come back. And unfortunately, that's what the literature shows. And that perhaps we need to do more. Instead of extinguishing a memory, we need to reconsolidate or change a memory. And so that's the direction that I went.
Okay. So I want to ask about memory reconsolidation, but first I want to ask about another term that you're using called destabilization. And I haven't really heard that used in the way that you're using it. I kind of have thought of destabilize, thinking of destabilization is like, I'm destabilized because I've been through a traumatic experience. My emotions aren't regulated. My nervous system is, activated in fight flight. But you're talking about it's almost like dislodging something,
right. I'm speaking of the memory, not the person, right? And I should make sure I'm very clear about that. I'm sure I was not. The memory is very difficult to take apart when it's a traumatic memory. If it's like, I read a sentence in a book today and I need to change it, it's wrong a little bit, or I have adapted information, new information, that is so easy to update. There wasn't a ton of norepinephrine released while I was reading. It's not like locked in there. And that's what they believe does it. And although they're not sure exactly why trauma locks things in. So yes, destabilization, as I'm using it, refers to the actual traumatic memory. How do we take it apart and then make positive changes to the emotions, the body sensations, the thoughts we have about it before we use norepinephrine again on purpose, activate someone, in the therapy room with a therapist to close it back up again in this new form? So you're just so astute. That was a great question.
Yeah, it's just a different use of that term I hadn't heard before. So I thank you for clarifying that. Now let's talk a little bit about memory reconsolidation. This is something I know from my energy psychology techniques. I feel like it's also relevant with things like EMDR and brain spotting. What exactly is memory reconsolidation, and why is that so important when working with unresolved trauma?
Okay. So memory reconsolidation, in simplest terms, is 3 steps. I think sometimes people use it in maybe a not fully comprehensive way. But what the literature tells us is, as I was saying, you have to take the memory apart, or what they call destabilize it. And that requires, certain chemicals. Then you change those associations that I was talking about, emotions, body sensations, and thoughts, and what is connected to that memory. And then you have to close the memory up, which is technically called reconsolidation. And that's sometimes the whole process is referred to as reconsolidation, because you can't close a memory back up if you haven't opened it up to begin with, if you haven't destabilized it. So the problem, I think, sometimes and believe me, I practice EMDR. I'm EMDR certified.
Mm-hmm.
The thing about EMDR is these movements of the eye, back and forth, lateralized saccadic eye movements, have been demonstrated to turn off what we call the basolateral amygdala, or the emotional memory center. So that's a great way. Think of it more as parasympathetic. It's calming. It turns off big emotions, not necessarily all bad emotions, but big emotions. That's something people need to realize about
Mm-hmm.
the emotional memory center. It's not just fear. It can be happiness and joy, but these eye movements have been demonstrated to calm that all down. So that includes fear, and that's a good thing. The thing is, you have to do the closing up, and then you also get some positive changes, right, with the EMDR. But sometimes people get stuck, and
Yeah.
I think, right, and I think it's because we're not taking that final step. We're not closing the memory back up again. You're never telling anybody when you're treating them strictly with EMDR or brain spotting, hey, now we're going to activate you on purpose. That sounds weird even. So that's an interesting thing. Now, therapists have been very, understanding of this and accepting, and they understand it, but you could see why, a person might think, why would I want to activate someone? Well, don't forget, they're with you in the therapy room. It's controlled via an eye movement that we'll talk about, and we shut it off again. So it's an eye position that's 60 degrees up, that's held in the literature. There is a research to show that if you hold it there for at least 10 seconds at 60 degrees, so this is 0, straight up is 90, and you wouldn't even want to try that, and you couldn't do it. 60 degrees is about 2/3 of the way. And you hold it there for 10 seconds. That has been shown to turn on the sympathetic nervous system. It actually turns on fight or flight. It turns on the basolateral amygdala. So any emotions that were associated with that memory. But what we find, and we're very, happy and openly admit, the first time, so we do a number of eye lifts in a session. The first time a client does this, they turn on sympathetic. They might feel a little bit scared. And then we have them lower their eyes. We ask them a few questions. We lean into what body sensations they're having, what emotions they're feeling. And then we do another eye lift, thinking about the traumatic incident. And what we find, Adriana, is that as we move through these eye lifts, by the time we get to sometimes the third one or the fifth one or whatever it is, they're starting to go, maybe they're numb or they're scared initially. And then they're like confused. That's super common. And then they're going, how dare they? They move towards empowerment and healthy anger, and they feel it in their body. And we, as the therapists, lean into that. Our questions are very explicit after each eye lift. What emotions are you feeling? Where are you feeling them in your body? What thoughts are you having? But we try to stay brief, right? We just want to live, like you were saying before, kind of. We want to be bottom up, not top down, right? So then they were like, I feel so empowered. That's a word they use. The word confident. Suddenly people were, I didn't ever use the word confident in these sessions. Clients were using it with me. Now we do use it, right? A little bit of neurolinguistic processing, because that's what was reported to us. So they move through a series of eye lifts. They've also done ASMR. They do re-narration. They get to re-narrate in their minds what actually happened. Their brains know that's not what happened, but we let them re-narrate it in any imaginative form that they want. And suddenly they're like, I'm big and giant, and I stepped on the person who did this to me, or whatever it might be, or I pushed them away. My hand got really big and I pushed them away, whatever they come up with. So they have all these feelings of empowerment and confidence at the same time as activation. That shuts the memory back up again. The literature also tells us we want to repeat this. So we want to do parasympathetic, positive changes, sympathetic, positive changes, repeat. And that's what we do in one session. And it is striking, the results that we're getting. People say, nothing has ever worked for them like this. It's really been amazing to be a part of.
I think it's really interesting, the piece about, the sort of, I forget what you called it, but like sort of imagining the empowerment and
Redirection.
They use this in matrix re-imprinting as well, where you're re-imprinting like the memory.
Very important. Yes.
Yeah, and you get to like, you're not denying that the trauma happened, but you're giving yourself, like, maybe the person apologizes for what they did, or they get to remove that abuser and put him somewhere else, send them away, whatever it is.
Change the way it feels.
Change the way it feels, which is interesting because I feel like that is a piece that has been missing from some of the other modalities that are really good at working with the initial activation of the memory itself, all the of it, getting the nervous system now calmed down, getting the body to recognize, hey, we're safe, it's okay to calm down. And then because you've now basically taken, so I think of snow globes sometimes. You've taken the memory out, you shook it all up. Now things are settling down and it's more peaceful in a different configuration. But this last piece you're talking about seems different from some of those other modalities.
It really is. The re-narration is done in other treatments. I will not, ever say it's not. But we think that you have to affect things like use somatic techniques like the ASMR techniques I didn't really describe, and the eye lift that is held in place. It's important to hold it there to help people access things like empowerment, and exactly like you're talking about, reconfigure the thoughts, yes, with re-narration, but also the body sensations, right? And not just, oh, I'm calm now, but also I'm empowered, I'm confident, I'm strong. And the feelings that go with it then get connected, largely because of the re-narration. It's a key piece. You're right to absolutely recognize that. It's a key factor.
Now, how do you work with folks who maybe have pre-verbal trauma, or they don't remember very clearly, they don't have a clear memory of an experience, or it just was something that happened over and over? Like, how do you work with that aspects of the more complex PTSD?
Such an excellent question. So first I want to clarify that at this time, we only use Tholáge with adults. We don't use it with children and adolescents because such a big part of the treatment is to get in touch with, not to talk about it, but to get in touch with feelings of healthy anger toward a caregiver. We're not ready yet. We want to do research around it, and it's so complicated. But yes, sometimes somebody, and I myself have had a client who had severe OCD, I would call it severe OCD, and was really impacting the client's life. And there were some allusions, references to something that probably happened when this person was pre-verbal. They did have before they ever did Tholáge, they had dreams that may have been associated with it. And I don't want to identify the person by saying something else, but we kind of believe that it was indicative of something that happened to them, and it made sense, right? So what we do, because we don't know what may or may not have happened, and we're not trying to implant memories. That's not what the re-narration part is about. That's only when we know of a trauma. What we'll do instead is we'll go to what's happening in their life now. Now, I was trained in the psychodynamic perspective at Northwestern. That's what they teach. So I believe very strongly, and from personal, just witnessing the world and my own life, that what happens in childhood shapes us and creates patterns, and people will reenact. That's what it's called, reenactment, the same situation over and over. Maybe they're picking a different partner every time, but it's still mom or still dad, right? And they're trying to fix it. This time I can fix it. We begin with those parts. So you can often, we'll take something that happened 2 weeks ago or something that happened 5 years ago. And we'll use that as a starting point. And sometimes that will lead us to earlier traumas, and they will remember something. We are very careful about saying we're not trying to implant memories. We are not trying to do that. We actually also don't want anybody, we really literally tell clients, we don't recommend you talk to your caregiver about your new feelings of healthy anger, but we do want you to feel it, because when you don't is when you get symptoms. But if what we do see is, and I can tell you about the OCD client and one other client, we have had people certainly remember pieces of memory right in the middle of Tholáge. For instance, I had a client who had trauma decades before, knew a little bit about it, had, again, I'm not trying to bash EMDR, I do practice it, had done EMDR weekly for about 6 months, remembered a little piece of it that she hadn't remembered before. And I promise you, because we have it recorded and we show it in our training, she did her very first session of Tholáge and started to go, he's wearing this, it's this color, he has a pot belly. She just started to say things and she was blown away, and I was trying not to look stunned, but I was stunned. It's really amazing. It's not a primary goal of Tholáge. Right. We're trying to access emotions and reconsolidate the memory, change the way the memory shows up for the person in their life, for the person as they live their life. But sometimes people do say that, or more frequently what we'll hear is, I thought about things I haven't thought of in years. So there is that, because it acts on the hippocampus too, norepinephrine and these chemicals. Oxytocin is released when we get that tingling sensation of ASMR. We release oxytocin that acts on the hippocampus. So I, of course, have a ton of neuroscience. I write about it, I present about it, I study it. But yes, for the average person, you just want to know the outcomes. And I will tell you briefly, with the OCD client, that person had picked a partner who was highly abusive, and just a trigger alert, was abusive in a sexual manner as well, but couldn't get in touch with anger even toward that partner, much less toward the caregiver, who was not allowed to be with the client after a certain age. So we do think something probably happened. But we had this person do Tholáge. They didn't actually access anger in the treatment, but when they came back a week later, they said, I had a dream. I was driving in my own car, but I was in the back seat. My ex-partner was driving my car, and I was yelling, why are you driving my car? I should be driving my car. It was just so beautifully symbolic. And really, one of the things we ask people to look for after a treatment of Tholáge is like, did you have a dream? What was it? They will often not think it was anything significant. The therapist will see that it mirrors exactly what we did in treatment.
Yeah.
It's really interesting.
Really interesting. So if there are, practitioners on here, mental health, professionals who want to learn this technique, what does the training look like?
Oh, that's a great question. The training takes part right now, we're doing it over 2 weekends. So you actually learn the activating protocol first, because the activating protocol has been studied on its own. It works all by itself. When you lift the eye up, I myself have watched a neuroimaging study. You turn on the sympathetic, the ventromedial prefrontal cortex, you know that the sympathetic system is activated. When you lower the eyes back to the center, you turn it off and the body goes into like a rebound parasympathetic. So you can do this whole process really with just phase 1, but we really like to teach the ASMR piece because it just feels so good for people. They love it. So we teach the activating protocol in 1 weekend. It's all virtual. We teach the deactivating ASMR protocol, or we call it the attachment protocol, because it helps people get through the difficulty of being alone or being in isolation as well. We teach that as a second virtual weekend. And essentially then you have a year to complete certification, which is supervision sessions that occur live. And those we include that in one price so that it's not a mystery. We also provide the supervision from our own company so that we know exactly what is being taught and it's done properly. Because as you can see, this is pretty technical, and it's I mean, I could talk even more details about the right, and I'm not going to, but I could. It's very technical, and we want to be careful. And so right now, it's all done in-house, if you will. That's how it's done.
And do people need to be like a licensed mental health professional to do this, or is this open to other kinds of practitioners, or, how does that piece work?
We prefer licensed. Well, we will only work with licensed or pre-licensed mental health therapists. When we get pre-licensed folks or students who are like in internship, as opposed to, we don't like practicum so much as internship because you need some experience. We prefer that the supervisor takes the training as well. Just so it's, and really we may even move away from that and just do folks who have graduated, who are not students. But at the moment, we're still including students. But it's a good question.
Yeah. And then my last question, as we move toward wrapping this up, is for the person who may be seeking a treatment with Tholáge, I know it's varies so much, but is there sort of like an average or typical course of sessions that you find?
That's a great question. So the way it works is you do have a few sessions that we call just the psychoeducation sessions. Then you'll have a session that's all about planning exactly what you're going to do in the treatment. And then you'll have a treatment session at least 3 days later, preferably at least 3 days, or a week or two. We'll have a debrief. And it's the debrief where people are blown away in the treatment and on their own. And we ask them to keep track of like certain things, what emotions, dreams, different interactions that they have with folks, insights into themselves, lessening of symptoms, of course. We really emphasize that they should keep track in the days and weeks after. And then the debrief is really fruitful and very exciting. It's very fun for the therapist too, because they can really see what has happened. How many treatments are required, of course, as you said, can vary. The way I think of it is you can address, like, I don't know if this is the proper use of the word clusters exactly, but clusters of traumas that happened in people's lives, if it's complex trauma. With a single incident trauma, it's often just one session. Sometimes even with complex trauma, it's very few sessions. It depends. It depends on how deep, how frequent, how early was the trauma. It can take more, but it's very powerful. So we have folks that are starting to do intensives, and it can and has wrapped things up for folks very quickly. But I'm more cautious. I like to say with complex trauma, I like to say a couple of years, just of working through it, because you're not doing it every week. You might do Tholáge, and then, sometimes people will go out, they'll make a choice. Something will happen in their life through no fault of their own ever that creates a new trauma, right? And so there's that re-traumatization piece. Maybe it's 3 months before you ever do another treatment, but you can do it really quickly. And that's the point.
Right. If people want to find out more about this or your work, where do they go?
You would visit it, whether you're a patient or a clinician. If you're a patient, on our website, which is tholáge.com, so it's THOLAGE, tholáge.com, we have a directory. So you choose your state or your country, because we are in 3 countries and close to 30 states at this time. And you can find a practitioner. You can also reach out to me. I have a page on the website where I have some contact information, and I can try to find someone for you if they're not in the directory. Also, if you're a clinician, that's where they would register for the training. And we occasionally will have lunch and learns too, where you learn more about the chemistry than perhaps we talked about here, and just experience. And that we also actually have them experience the treatment themselves, the clinician.
That's great. Yeah.
Same website.
Fantastic. I love hearing about these new powerful modalities. I love it when we have a science now. Science is catching up. We can explain like how all this is working. And I feel like it gives people a sense of maybe security or trust and understanding like the science behind these things and why this modality works. So I appreciate all that you're doing, especially in getting that, more research out there. Any final thoughts for us?
Oh, I'm just so grateful to you, because we do want to get the word out there. I just would love for people to understand. I'll just give like a little tidbit. Go ahead, and if you are able, please move your body. Move your body if that's feasible for you. It releases a lot of these same chemicals that we're talking about. Remember that if you do get in touch with an emotion that is toward a caregiver, you're probably not going to change that person. It's more about you organically feeling your feelings either in the moment or the same day. Because emotion suppression sometimes is okay, right? We can't, in a business meeting or whatever, you can't act on your emotions or even sometimes process them privately. But do recognize how important it is to organically feel your own feelings, not necessarily or ever act on them. And also just make sure you're moving your body and being as healthy as you can.
All right. Thank you so much, Deanna. Thank you, everyone who has tuned in today. If you have found this information helpful, please do help us get it out there. Share this podcast, subscribe to it, like it, comment, rate it, all the things you can do to help the algorithms find the people who are looking for this information and who really are looking for relief from those struggles that they have had. So thanks, everyone. We'll see you next time.
Thank you for joining me for this episode of Kaleidoscope of Possibilities, Alternative Perspectives on Mental Health. This has been Dr. Adriana Popescu. If you enjoyed this episode, please like and subscribe and share with others. To find out more about me, my guests, and more, please visit my website at adrianapopescu.org. See you next time.